So MRD cells, it's impossible to detect it, so we need more sensitive techniques to detect them. And from here you can see that we are talking about multiple subpopulation at the end, up to here. So we have 1, 2, 3, 4. All those cells exist inside in the bulk of primary tumor. This is something that you need to hear about, how fast and how early cancer can spread, unfortunately.
Although angiogenesis is usually suppressed or quiescent in adults, it plays a critical role in the growth of cancerous tumors. Small tumors less than 2 millimeters in diameter, such as the one shown here, don't require angiogenesis. They are able to tap into existing capillaries for their oxygen and nutrient needs during the early phases of tumor growth. However, once the tumor reaches 2 millimeters in diameter, as shown here, existing blood vessels are unable to supply the growing tumor with all of its oxygen and nutrient needs. In order to grow larger than 2 millimeters in diameter, the tumor must develop its own blood supply, or neovasculature, by turning on the angiogenic switch. Angiogenesis is the critical process that leads to the formation of neovasculature, which is beginning to happen here. Angiogenesis and the formation of neovasculature allow the tumor to grow much larger than 2 millimeters in diameter. The newly vascularized tumor undergoes a burst of growth and may increase exponentially in size. Angiogenesis is also an important process that helps the tumor grow into and invade adjacent tissues. The tumor neovasculature also increases access of cancer cells to the blood supply, increasing the likelihood that some cancer cells will break free of the tumor, enter the blood supply, and be carried to distant sites in the body where they can form metastases or new cancerous tumors. Let's take a closer look at angiogenesis by zooming into a close-up view of a cancer cell next to a blood vessel. To understand how angiogenesis works in tumor cells, we need to examine it at the molecular level. Angiogenesis depends on the balance of pro-angiogenic factors which stimulate angiogenesis and anti-angiogenic factors which inhibit angiogenesis. Many tumors secrete high levels of pro-angiogenic factors as seen here, thereby tipping the balance in favor of angiogenesis, which promotes the growth of neovasculature to nourish the tumor. In these tumors, the angiogenic switch is turned on. A pro-angiogenic factor known as vascular endothelial growth factor, or VEGF, is recognized as the central mediator of angiogenesis because it plays the most prominent role in stimulating new blood vessel growth. In order to stimulate angiogenesis, VEGF must bind to specific receptors, called VEGFR, located on blood vessel endothelial cells. Upon binding to the receptors, VEGF stimulates endothelial cells to proliferate, migrate, degrade the basement membrane, and form new blood vessels. Another important group of proangiogenic factors are matrix metalloproteinases, or MMPs. MMPs are enzymes that participate in angiogenesis by also degrading the basement membrane and extracellular matrix of the existing blood vessel, which allows new blood vessels to sprout from existing vessels. These new blood vessels grow towards the tumor, as seen here, to supply the cancer cells with oxygen and nutrients to support continued growth of the tumor. Let's zoom back out and take another look at angiogenesis. Once the tumor has developed its own blood supply, it is then free to grow much larger than 2 millimeters. The secretion of proangiogenic factors by the tumor, and especially MMPs, helps the tumor invade adjacent tissues. The neovasculature associated with the tumor also increases the likelihood that cancer cells will escape into the bloodstream and metastasize to other locations in the body. Angiogenesis, therefore, is an important process that plays a key role in the proliferation of cancerous tumors, tissue invasion, and metastasis.
So as you realize, 0.2 millimeters is essential for a primary tumor to develop new vessels and spread. So what happens of what we call early stage of disease? It's really doubtable how early it can be. And this also has been proved by statistics, because we already know, especially in breast cancer, it was extensively studied, that many women with breast cancer in early stage, 2 centimeters or less, has performed surgically removed. They have been assured that there is nothing more, and suddenly they relapse of the disease. So what happens then? That's why we developed new detection methods, perform genetic profile, and there are also other tests available to detect or point out the risk of relapse, like Oncotype DX for breast cancer, which actually measuring the number of 21 genes can give you information about the risk of relapse when you are in very early stage of disease, using a paraffin block. So macroscopic clinical reality is not always the same as the microscopic world in a laboratory and what happens in cellular level. So here what information we may have from circulating, qualify and quantify the circulating tumor cells. First of all, we can see what we call DNA ploidy, which is actually a number which compare the normal DNA concentration with the DNA concentration of tumor cells. So if the DNA index is between 1 and 1.5, then we talk about diploidy or ploidy, as we said. If it's over 1.5, then we talk about hyperdiploidy, and when it's less than 1, then we have hypodiploidy. But what is the relevance with the clinical reality? The relevance is up there. This data comes from multiple myeloma. Hyperdiploidy, they have median survival of 58 months. Hypodiploidy only 12, and diploidy 28, irrelevant if the patient received therapy or not. So it means that already the informations are there, how aggressive our cancer cells are, even from simple features. And of course, the circulating tumor cells can divide it in M0, M1, and M2 crisis according to specific abnormalities of specific genes, who mainly involve in regulation of cell cycle and immortalization of the cell, like P16, P53, and human telomerase. So let's see what we know about the